Good morning, everyone, seniors and friends. Thank you, Vision 2020, for giving me the opportunity to do this talk. I will be taking up endophthalmitis, current clinical management. The main components of postoperative endophthalmitis care are infection control, removal of inflammatory debris from the vitreous cavity, and to block the inflammatory cascade and its effects on the retina, to treat the complications of infection, to minimize future complications whether from the infection or from treatment itself, and to prevent further episodes. The mainstay of infection control in infective endophthalmitis is antibiotics via various routes and vitrectomy. The most effective route of antibiotic administration is intravitreal, as it achieves high concentration of drug in the vitreous cavity. Initially, Payman et al. Suggested the use of cefazolin for gram-positive foci and aminoglycosides for gram-negative bacilli. Currently, the preferred empirical antimicrobials are glycopeptides, beta-lactam antibiotics, and voriconazole. Specifically coming to bacterial coverage, spectrum and sensitivities support the empiric use of vancomycin for gram-positive bacteria and ceftazidime for gram-negative bacteria. In situations where there is a partial response to intravitreal antibiotics with decrease or resolution of hypopyon and improvement of fundus glow, further injections are not required and medical management is continued. The EVS recommended re-injection if infection is worsening 36 to 60 hours after first injection. But decision to re-inject shouldn't be taken lightly, since repeated injections increase the risk of retinal toxicity. Also, biofilm production and sequestration by bacteria can cause reduced response to antibiotics. Large number of newer studies recommend that if there is worsening 48 hours after the first injection, the patient has to be taken up for vitrectomy. There are several complications of intravitreal antibiotics, including corneal opacification, retinal toxicity, and macular infarction, hemorrhagic occlusive retinal vasculitis associated with vancomycin injection, etc. Use of systemic antibiotics is controversial as most of the drugs have poor ocular penetration. EVS concluded that use of systemic antibiotics does not affect the final visual outcome. The newer drugs like meropenem, linezolid, and fourth generation fluoroquinolones are documented to have achieved therapeutic levels in vitreous and thus can be used. Coming to local antibiotics, topical or subconjunctival, a combination of two local antibiotics is preferred during initial presentation, one for gram-positive and one for gram-negative. CVS recommends vancomycin and amikacin for gram-positive and gram-negative respectively. Once the antibiotic sensitivity is determined, targeted intervention can be done. Coming to the antifungals, antifungals have never been considered as primary care in sporadic endophthalmitis because of lower incidence. But in places with less rigorous surgical environment, voriconazole is added along with ceftazidime and vancomycin. In case of culture or smear confirmed fungal endophthalmitis, intravitreal voriconazole or amphotericin B is given with or without vitrectomy. Coming to the vitrectomy, it has several advantages over conservative therapy. It improves retinal oxygenation, reduces inflammatory load within the eye, provides specimen for diagnostic evaluation, allows direct inspection of retina, reduces the load of infection, reduces severity of disease, and accelerates visual rehabilitation. There are actually two schools of thought regarding timing of vitrectomy in endophthalmitis. One is based on EVS and another on complete and early vitrectomy for endophthalmitis study. EVS concluded that early vitrectomy was only beneficial in patients with visual acuity of perception of light or worse, that is, the most severe cases. Hence, delaying vitrectomy has become a norm for patients with better presenting vision. However, results of EVS do not really reflect the modern practices and methods. Also, EVS recommended removal of only cortical vitreous. The separation of posterior hyaloid and complete vitrectomy were avoided. Kuhn et al. In a large case series advocated early and complete vitrectomy, including removal of posterior vitreous to remove toxic load and inflammatory debris and to prevent exudates from settling on the macula. With advent of microsurgical vitrectomy, more and more surgeons are preferring early vitrectomy nowadays. Coming to the inflammation control, inflammation plays a huge role in pathogenesis of endophthalmitis. EVS used oral corticosteroid 1 milligram per kg of body weight a day after the intravitreal antibiotics were started, and intravitreal corticosteroid was not a part of EVS protocol. But intravitreal steroids, several Indian studies have recommended and shown that intravitreal dexamethasone reduces inflammation faster, but again, it does not significantly affect the final visual outcome. Cycloplegic agents are essential part of treatment that relieve ciliary spasms and prevent synechia formation in patients with elevated intraocular pressure. Oral and topical anti-glaucoma medication has to be added. Hypertonic saline may be needed in cases of severe corneal edema. Coming to the part of infection prevention, the current strategy of infection prevention is directed to the patient's conjunctival flora as much as controlling the environment and medical supply. The single most effective prophylaxis includes preoperative application of 5% povidone iodine solution to conjunctival surface and cul-de-sac. Bacteria has not yet developed resistance to the povidone iodine solution. Also, few viruses and many fungi are sensitive to povidone iodine. Other measures include preoperatively checking for lid infections, checking the patency of nasolacrimal duct, intracameral antibiotics at the end of the surgery, prompt repair of conjunctival erosions, and suturing any potential wound leak. Use of intracameral antibiotics again remain a controversial topic. The ESCRS recommended routine use of intracameral cefuroxime, but a large study conducted in Irvine Eye Care System on 2 million eyes undergoing cataract surgery showed that intracameral moxifloxacin reduced the incidence of endophthalmitis. But many other studies did not find compelling reasons to recommend routine and indiscriminate use of intracameral cefuroxime or moxifloxacin. One could consider use of intracameral antibiotics in high-risk situations such as one-eyed patients, diabetics, prolonged and complicated surgeries with vitreous loss, very elderly patients, and immunocompromised patients. Endophthalmitis needs to be differentiated mainly from toxic anterior segment syndrome. Other differentials include posteriorly dislocated lens matter, fibrinous reaction, phacoanaphylaxis, and various posterior and panuveitis syndromes. Toxic anterior segment syndrome is an acute inflammatory condition presenting within 24 hours of surgery with a severe anterior chamber reaction, limbus to limbus corneal edema, but there is no adnexal involvement and the patient responds dramatically to the steroids. Coming to the novel treatments, Naka Shizuka et al. Reported the safety and efficacy of 1.25% povidone iodine intravitreal injection followed by vitrectomy using 0.025% irrigation to treat endophthalmitis. Most of the cases resolved rapidly, good vision was restored, and no adverse effect were reported. The ERG results also suggested the functional improvement in inner retinal and outer layers after surgery. Microdevices, these are the experimental treatments. Microdevices such as biomimetic nanosponge are being tested to treat endophthalmitis caused by virulent pathogens such as Enterococcus faecalis. Lagro et al. Hypothesized that a biomimetic nanosponge which imitates erythrocytes could absorb subunits of cytolysine and decrease damage to the retina, preserving vision in endophthalmitis patients. My take-home message will be maintain a high level of suspicion in all cases, treat quickly and aggressively, start empirical therapy without waiting for culture results, and in case of cluster endophthalmitis, it's better to go for early vitrectomy rather than intravitreal antibiotics and waiting for the culture results.